And good morning and assalamu alaikum everyone. My topic today is about the cardiac MRI and cardiomyopathies, and I will try to put it in a series of lectures to describe the role of cardiac MRI and cardiomyopathies, followed by a series probably in cardiac MRI and congenital heart diseases. I'll try to focus on or to stress on some basic points for the acquisitions, as well as to stress on some points that we need to comment on during reporting the cardiac MRI in cardiomyopathies or in the next series in congenital heart diseases. I'm not going to go deep in the genetics and pathology of those cardiomyopathies, but I would rather to go and stress and focus on the main points that the MRI would or could be useful while reporting those cardiomyopathies. So let's start with some basics, or fly through some basics that might help for a good acquisition and quality of those cardiomyopathies. For example, there are available scanners in the market: 3 Tesla, 1.5, or 1 Tesla. Usually the 1.5 Tesla is preferred because it's less artifacts. 3 Tesla might be useful in or provide a better resolution, as a matter of fact, in stress cardiac MRIs, but it's more liable to produce some more artifacts than the 1.5 Tesla. You could use any available coil, as a matter of fact, but it's preferred that your coil or the vendor's coil to contain or include at least 8 channels or more in order to get a good quality for the images. Triggering using ECG or peripheral pulse, usually the ECG or the VCG would provide you with a better triggering, as the software or the MRI scanner will be able to detect the peak of the sharp R wave. A peripheral pulse unit could be used if there is no ECG available leads for an MRI, or that there is an irregular or arrhythmias that the MRI scanner cannot detect a regular or a good ECG triggering. At that time, you may use the peripheral pulse unit. But bear in mind that the peripheral pulse unit will provide you with a dome-shaped peak rather than a sharp peak in the R wave, which might make the triggering less homogeneous than an ECG. And for that reason, ECG is preferred than the peripheral pulse unit. It's better that someone has to attend a consultant or a specialist, a radiologist, or a cardiac imager from other subspecialties, just in order to check for the quality. For example, this patient was sent to quantify the shunt. This is a phase contrast, as you all may know. And the images were very bad, and we had to recall the patient or rebook the patient in order to get a good quality of the images. Although the sequence is 30 seconds, but no one did check before the patient left table. Another example is the nulling point of delayed gadolinium enhancement. As you may see, that the nulling was very bad. In this patient, this is another example. It's an Epstein. The clinical question was about the tricuspid regurgitation and the RV volumes. But the radiographer was alone, so he injected the patient contrast, which was unnecessary in this case. Triggering, so we all know that the heart is moving and it is in a moving environment, so we need to trigger the chest and the heart. And we mentioned earlier the triggering of the heart could be using the VCG or the peripheral pulse unit. Respiration is through the breath hold command, so breathe in, breathe out, and hold your breath. Or in pediatrics, where the chest volume is very small, so you could do it as a free breathing, and the partial volume artifact is minimal because the small volume of the chest. Triggering is either prospective or retrospective. Retrospective is the routinely used, and as you may see here, this is the retrospective gating, where the acquisition is throughout the whole cardiac or the entire cardiac cycle, and including the entire systole and the astole. That's why it's the routinely used triggering. Prospective might be used when there is severe arrhythmias, but as you may see here, so the triggering is at the R wave and it has to stop before the next cardiac cycle, which makes a very small part of the cardiac cycle being lost and not included in your numbers. So while you are doing the post-processing, bear in mind that there is a kind of underestimation or kind of an error in the measurements. Let's go through some basics of the views. We all know that those are the localizer and scouts, which are the orthogonal views, sagittal, coronal, and transverse. As you may all know that the heart is oblique to the left and downwards. So the axes of the heart is different than the axes of the chest. And therefore we need to find a common ground to identify the position and location of the heart, and a common ground between the radiology and all other subspecialties and clinicians in order to identify the position and the appearance of the heart. So let's go through how would we be able to plan the views. So using those localizers, if you on the axial cut, the axial localizer, if you used a line, if you told your radiographer to plan a line passing through the mitral valve toward the apex, so this is the left ventricle, left atrium, and right ventricle. So this line passing through the mitral to the apex would provide you with a view called the vertical long axis, or a two-chamber view, as you may see, left ventricle, left atrium. And again, the same line, if this line is passing through the image that we just obtained, so passing through again the mitral toward the apex, then it will provide you with the horizontal long axis, and the horizontal long axis is the four-chamber view. So as you may see, left ventricle, left atrium, and right ventricle. And using those two views, the vertical long axis or the two-chamber and horizontal long axis or the four-chamber view, if we use image, or we plan the next sequence perpendicular to the line that is passing through the mitral to the apex, or perpendicular to the interventricular septum, we would be able to obtain the short axis view. The short axis view is the backbone of the report, and it's the backbone of quantifying and assessment of functions and volumes. You could use a slice thickness of 7 to 8 millimeters with a gap 0 to cover the whole left ventricle, and then we would be able to identify the function and wall function and wall motion. As you may see, if all segments and all wall motion is going the same toward the center with the same kinetics, then we will call it normokinetic. If you could see one of the walls is going slower than the others, then we will call it hypokinetic. If you see one of the walls is not moving toward the center, then we will call it akinetic. And during systole, while all segments are contracting, moving toward the center, but you could identify one wall is moving outside the center to the opposite side, so we will call it dyskinetic. So we could use the short axis to quantify volumes, we could use the short axis to see wall motion abnormalities, and we could use the short axis to see the wall mass as well, whether there is hypertrophy or there is no hypertrophy. A septum above 12 millimeters, we will call it that it is a prominent septum and in the direction of hypertrophy, and then we could grade the hypertrophy, whether it's mild hypertrophy, moderate, or severe. Also, we could grade it as symmetrical or asymmetrical, because there are certain pathologies like systemic hypertension, aortic stenosis would cause symmetrical and concentric hypertrophy, while other pathologies, for example HCM, where there is asymmetrical hypertrophy more evident in the basal septum. Axial slices, yes, we could do also the volumes from the axial slices. So if you could produce cine axial slices covering the whole chest, which is axial zero angle, then you could obtain a normal axial of the chest, and you could use them in the post-processing similar to what we do in the short axis, delineating the endoborder and in the epiborder in order to obtain your volumes and functions. Usually short axis being performed in congenital heart diseases or in complex geometries or complex anatomies. And then we could calculate, of course, the ejection fraction if we were successful in the post-processing, delineating the endoborder and of the right ventricle and the left ventricle. A kind reminder, those are the views that we usually use in cardiac MRI: 2 chambers, short axis, right ventricular outflow tract, and this is the main views that we use throughout the cardiac scanning or the report